Why I choose this? Because I feel that in different kinds of cardiovascular disease, the management of hypertension might differ. It differs according to the age, it differs as based on the target you want to reach to, and it varies as which medication to start and what kind of plans you are having in these particular patients. And my talk will be about management of hypertension in cases of stable angina, in cases of acute coronary syndrome, in cases of heart failure of ischemic origin, in cases of atrial fibrillation, valvular heart disease, cerebrovascular disease. That will be the talk. And I'd like to thank Dr. Basata for squeezing me today because I'm traveling tomorrow, and this is practical things. There is nothing new in my data, but it's practical things that we can go through it one by one. Hypertension, as you know, represents a significant burden on health care. It is responsible for 62% of stroke and maybe 50% of heart attack. How can they? If you can see that 25% of the population, they have hypertension. And in people above the age of 65, maybe 50% of the population are hypertensive. The global mortality shows the impact of hypertension as the #1 cause of global mortality more than anything else, more than tobacco or high cholesterol. And you can see that hypertension can progress to cardiovascular disease, and it can end up in myocardial infarction, in heart failure and death. And that's why we'll be very careful when we look at the markers of the disease progression, the albuminuria, the LAD, LVH, CRB, etc., because the disease we can prevent progression of the disease in the early stages. Well, I believe that hypertension causes cardiovascular disease by two ways: either a direct effect through physical forces, hemodynamic, endothelial injury, or it could be due to unassociated factors, either sympathetic nervous system, RAS system, a decrease in release and activity of vasodilator, and most important is the presence of other risk factors. You can see here hypertension can end up in coronary heart disease either through endothelial injury, atherosclerosis, coronary heart disease, or through increased load on the ventricle, left ventricular hypertrophy, and so there is a mismatch between the myocardial need and the available blood. And there is a causal relationship with every 20/10% increase in blood pressure, there is doubling of the cardiovascular mortality. And the good news is with 5 millimeter mercury reduction, there is reduction in stroke and coronary heart disease. And as simple as 2 millimeter mercury decrease in the mean blood pressure, you can achieve 7% reduction in the risk of ischemic heart disease mortality. What about associated risk factors? There is a strong interaction between hypertension and other cardiovascular disease, namely hypercholesterolemia, diabetes, and mellitus, and smoking. And you are all familiar with these diagrams when you see that high blood pressure, if you have if we plot the age on one side, there is no mark, if you can have a pointer. There is blood pressures, and down you can see the hypercholesterolemia, and whether the patient is a smoker or not, you see that hypertension in association with risk factors end up with a high score, whether in high cardiovascular disease risk country or low cardiovascular disease risk factor. Even the relative risk, 10 years cardiovascular mortality, is a function of hypertension in association with risk factors. And when we talk about risk, can I have a pointer? I want to stress on a point that if you look at the patient at 60 years, where he is having low cholesterol and normal blood pressure and he is non-smoker, the 3% risk is similar to someone else who is 40 years old, but he smokes and he has high cholesterol and high blood pressure. So what is important to us is the physiological age, not the chronological age, because you can be 60 years, but you are 40 in terms of risk. So let us go one by one. Management of hypertension patient with established coronary disease. Until 2014, everything is not. Until 2014, in the guideline, there was no mention on management of coronary heart disease. But 2015, there was a statement on how to treat hypertension in patients with coronary heart disease. And in this case, and in year 2017, there was a specification. There are things that relate to the age-related issues, which is important because most of our patients are old. And what kind of target blood pressure, and what's the efficacy and favorable role in secondary prevention of stable ischemic heart disease, acute coronary syndrome, and heart failure. Age. Below the age of 50, the diastolic blood pressure is the most important thing, and above it is 60. Above 60, it's systolic hypertension. Give me another one, please. It's hard. It's important in elderly. You lower the blood pressure slowly, like the frog. You have to be careful, and the caution is advised in inducing decrease in blood pressure diastolic less than 60 millimeter mercury in patient with diabetes who is above the age of 60. And avoid to have a very wide pulse pressure. And the guidelines 2017, we have to differentiate between two kinds of elderly. The non-institutional patient who is 60 and above, but he is in good health, in whom the goal can be go to below 130/80. And in another patient who is old, but he has a lot of comorbidities. In this patient, we tend not to lower the blood pressure to below 130/80 and to watch the medicine we are using for the side effect. Now we go to what are the targets for blood pressure in coronary heart disease. It's one, up till 2015, it's less than 140/90 for patients for secondary prevention of cardiovascular event. But you can go to below 130/80 in individual with previous MI, stroke, or transient ischemic attack, or coronary heart disease risk equivalent. And when you have a stable angina with hypertension, the number one treatment is beta blockers, particularly in patients with previous MI. An ACE inhibitor can be added if you have prior myocardial infarction, left ventricular systolic dysfunction, diabetes. Thiazide can be added as well as number 3, and then you can have a combination if blood pressure does not. But if beta blocker is contraindicated and you think of non-dihydropyridine derivatives, you have to make sure that you don't use that in patients with left ventricular dysfunction. And if the patient has a high blood pressure, it's uncontrolled, you have to combine it with dihydropyridine derivatives. And stay away from beta blockers with non-dihydropyridine derivative, particularly in patient who has bradyarrhythmia. There is no special contraindication hypertensive patient with use of antiplatelets or anticoagulants. But blood pressure should be lowered without delay, because that's important concern, particularly when you use aspirin and platelets in a hypertensive patient. Lower the blood pressure, and you have to lower it without delay so that you will not have a risk of bleeding when you have an antiplatelet therapy. In 2017, it was clear there is two things. Blood pressure in patient with a stable heart disease should be below 130/80. Beta blocker should be used, but you should use the so-called GDMT, which is guideline-directed medical therapy, which are not all the beta blockers. It is atenolol, it is bisoprolol, carvedilol, and nebivolol. This kind of guideline-directed medical treatment is preferred in 2017 guidelines. The important thing is In adults with stable ischemic heart disease and angina and persistent uncontrolled hypertension, you can add dihydropyridine, and you have an MI, then you stay on beta blocker for 3 years, and that's 2A, or beyond 3 years in 2B if needs arise. So simply, in hypertension with stable ischemic heart disease, you reduce the blood pressure to below 130/80 and see if patient has angina. Then you have to add a dihydropyridine derivatives. And if he does not have an angina, you can choose whatever you want, a dihydropyridine or thiazide diuretics. Now we're coming to hypertension with acute coronary syndrome. The same thing, you have to start with beta blockers to make the diastole, to prolong the diastole so you improve the diastolic filling. And if the patient has ongoing ischemia, it's justifiable to use esmolol IV, but it is important in patients with acute coronary syndrome not to give him a beta blocker while he is congested. You have to give him diuretics, you have to stabilize before giving a beta blocker. Nitrates is important, lower the blood pressure, particularly in the IV, but it should be avoided if patient has right ventricular infarction or having a hemodynamic instability of hypotension. Non-dihydropyridine derivatives can be going, but you have to look carefully at the left ventricular dysfunction. And you can add dihydropyridine derivatives to the patients with beta blockers in order to relieve the anginal pain. ACE inhibitors or ARBs, these used in patients with anterior MI, hypertension persists, you can add them. So in the management of acute coronary syndrome, the target should be less than 140/80. In patients with acute coronary syndrome who are hemodynamically stable, and at the time of discharge, they should be less than 130/80. Blood pressure should be lowered slowly, and the caution is advised to avoid decrease in diastolic below 60 millimeter mercury because this reduces coronary perfusion and worsens ischemia. 2017, there was no mention on management of hypertension in acute coronary syndrome. So moving to heart failure of ischemic origin, what's your choice? The treatment of hypertension in patients with heart failure should include management of risk factors. That's essential. Drug has been shown to improve outcome in patients with heart failure with reduced ejection fraction, generally also lower blood pressure. Patients should be treated with ACE inhibitor, a beta blocker, also the GDMT, the carvedilol, metoprolol, bisoprolol, and nebivolol, and the aldosterone receptor antagonist. Thiazide diuretics. And in patients with severe heart failure and those with severe renal impairment, loop diuretics should be used for volume control, but they are less effective than thiazide in lowering blood pressure. And diuretics should be used together with ACE inhibitor ARBs in heart failure. Studies have shown equivalence of benefit of ACE and ARBs, and that's important. In heart failure, ACE and ARBs, they are equivalent in the patient, and you can see that in the candesartans and valsartan in heart failure with reduced ejection fraction. Either class of agent is effective in lowering blood pressure, and that's class 1 level of evidence A. You choose any of them. Coming 2017 in heart failure, in adults with increased risk of heart failure, the optimal blood pressure on hypertension should be less than 130/80. And in HFrEF, adults with HFrEF, reduced ejection fraction and hypertension should be prescribed GDMT again, titrated to attain blood pressure less than 130/80. Non-hydropyridine CCB are not recommended in the treatment of hypertension. In this kind of patient with hypertension and reduced ejection fraction, never to use non-hydropyridine derivatives, and it is harmful. In HFpEF, you use the diuretics and the volume overload, and then you can use ACE or ARBs. Beyond the pharmacology, you have to look for exercise training, sodium restriction, smoking cessation, reduction of risk factors like dyslipidemia, diabetes mellitus, and obesity. Now we come to other comorbidities in a few minutes. Cardiovascular comorbidities. Atrial fibrillation. The recommendation for atrial fibrillation is to use ARBs. Most of the data from the life study and ongoing one that the ARBs are beneficial in patients with hypertension and atrial fibrillation because of the afterload, they unload the ventricle and they prevent the stretch of the left atrium. Second thing, valvular heart disease. You have to start at gradually titrating upward low dose. And in patients with aortic regurg, avoid beta blockers. Why you avoid beta blockers in aortic regurg? Because you are increasing the diastole and you are increasing the regurgitation. In aortic disease, beta blockers are important. And they are the best treatment that preferred antihypertensive patient with hypertension and thoracic aortic disease. When you talk about some difficulty. Peripheral arterial disease, there is no preference. You can use any medicine in peripheral arterial disease, but stay away from those who are causing peripheral vasoconstriction. Now the final two slides. Actually, one of them in hypertension in patients with acute intracranial hemorrhage with hypertension. And it is very important not to tend to lower the blood pressure unless the systolic is above 220. Because when you above 220, systolic blood pressure lowering should be used, and it should be with IV infusion so that you can easily monitor the blood pressure. And the lowering of the blood pressure should not exceed 10 to 15% of the mean pressure. No attempt should be made to lower the blood pressure in the patient who are below 220, because bringing it to less than 140 at the time of the acute intracerebral hemorrhage, it causes harm more than benefit. And when you talk about ischemic stroke, it is very important to do one important thing, to see if the patient is eligible for IV thrombolysis or not. If the patient came for the first 3 hours and you will give him an IV thrombolysis, you have to make sure of several things. Number one, the systolic blood pressure should be lowered to 185 and below before you start. Number two, that the patient is not on any oral anticoagulant. And number three, that he is coming during the time, the 3 hours that you can interfere. And when you start with the 10% of the dose over the first minute, and the rest will be given over 1 hour. Other than this, don't lower the blood pressure except if it's above 220, because if you lower it further, you are going to increase the vasogenic edema and you are going to reduce the flow. I believe that this is my last slide, and I believe that in briefing we'll be able to give you some guidelines on the management of hypertension in various forms of cardiovascular disease. Thank you very much.